In this technical note, we describe the senior author's preferred technique for arthroscopic posterior labral repair and reverse remplissage. The patient is a 25-year-old professional male hockey player who sustained a left posterior shoulder dislocation 2 weeks prior while checking during play. Examination revealed a positive posterior load and shift test with no strength deficits. MRI showed the posterior labral tear and a small reverse Hill-Sachs lesion. The patient is placed in the beach chair position and examination under anesthesia demonstrates a grade 3 posterior load and shift. A standard posterior arthroscopy portal is established as well as anterior-inferior and anterior-superior portals. The arthroscope is then moved to the anterior-superior portal and the posterior labral tear and reverse Hill-Sachs lesions are identified. A posterior-inferior portal is made approximately 4 cm distal to the posterior lateral corner of the acromion. The posterior labral tear is then debrided using a shaver to create a healing surface. The capsulabral tissue is elevated from the posterior aspect of the glenoid to allow for adequate mobilization for repair. A 1.8 mm knotless fiber tack anchor is then drilled into the articular margin of the posterior glenoid and placed in standard fashion. The sutures are then pulled to set the anchor in the bone socket. The repair suture is shuttled through the anterior-inferior portal. A straight crescent suture lasso is then passed through the capsulabral tissue and the repair stitch is shuttled using a nitinol wire. A number 5 ethibond suture is utilized as a counter-tension stitch while shuttling the repair suture through the anchor, as this aids in preventing tangling or twisting of the repair suture. This allows for smooth passage. The repair stitch is shuttled through the anchor and tensioned appropriately to reduce the labrum to the posterior aspect of the glenoid. A second 1.8 mm knotless fiber tack anchor is then drilled into the posterior superior aspect of the glenoid. A suture lasso is again passed through the capsulabral tissue and the repair stitch is shuttled through the anchor in a similar fashion to the inferior anchors and tensioned. Additional anchors may be placed as needed depending upon the tear pattern. With the arthroscope switched to the standard posterior portal, attention is then turned to the reverse Hill-Sachs lesion, which is debrided with a shaver from the anterior superior portal to create a bony bed for healing. Care is taken to avoid damage to the overlying subscapularis tendon. A straight crescent suture lasso is utilized from the anterior-inferior portal to pierce the lateral subscapularis tendon from anterior to posterior, and the nitinol wire is used to shuttle a 1.3 mm suture tape. The posterior limb is then retrieved through the anterior-inferior portal. An appropriately sized sponge is placed in the reverse Hill-Sachs lesion, and the suture tape limbs are then loaded into a 4.75 mm swivel lock anchor. The anchor is placed in a standard fashion with each suture limb tensioned individually. The sutures are then cut and the repair is assessed, demonstrating excellent reduction of the lateral upper subscapularis into the reverse Hill-Sachs defect. The arthroscope is switched back to the anterior superior portal. A suture lasso is utilized from the posterior portal to shuttle a 0 PDS suture around the posterior portal and tied into the posterior aspect of the capsule to provide deep closure. This step is critical to maintain posterior capsular tension in patients with posterior instability. Our rehabilitation protocol begins immediately post-operatively.